Good morning, everyone. Today we will be discussing about the off-field assessment. Off-field injury evaluation or off-field assessment. The detailed evaluation on sideline or in clinic setting. May be the evaluation of an acute injury or one several days later following acute injury. It is divided into four components: the history, observation, palpitation, and the special test. In the HOPS, we evaluate in the following order. First, we take the history of the patient. Then we observe the patient. We see the certain observation, if its general condition is okay, if there is any scar, if there is any swelling, if there is any tenderness. So that, then the range of motion. Then we check the strength of the patient, neurovascular, the special test, then the joint mobility, then we palpate, and then the functional test. The history. History, we obtain the subjective information related to how the injury occurred, the extent of injury, the mechanism of injury, inquire about previous injuries, illness that may be involved, as well as past treatments. We ask the following questions: that what is the problem? How and when did it occur? Did you hear or feel something? Which direction did the joint move? And we characterize the pain, if it is local or referred. Then moving on to the observation, we see the asymmetries, postural and malalignment or deformities. How does the athlete move? Is there any limping? Is there any difficulty in walking? We see the gait of the athlete, if he is able to walk properly, if there is an quadriceps gait, giant limping gait, a movement abnormal, if he is able to perform the movement pain free. What is the body position? It is open pack or loose pack. The facial expressions, if it is painful, the facial expressions of the athlete, the abnormal sounds, if there is any crepitus, or is there any other abnormal sounds. We see the swelling, heat, redness, inflammation, swelling, or discoloration. Moving on to the palpitation, bony and soft tissue. The special test we use to detect the specific pathologies. Every joint has a specific test. The shoulder complex have the different tests. The knee complex have a different test. The hip complex have the different tests. Wrist joint, ankle joint, and etc. Assessment should be made bilaterally. We compare inert and contractile tissue and their integrity. Then we see the range of motion of the assessment. We see if there's firm and feel, the active movement, the passive movement, normal versus abnormal endpoints, the manual muscle test, goniometric measures versus the digital inclinometers. Here's a tool to identify, check the range of motion, the different planes and axes. Here's a goniometer, as you can see. There's an polymeter. Moving on, the neurological and circulation assessment. You see brain, if there's any brain injuries and concussion, the cerebral cranial nerve function, the cerebellar function, sensory and motor function. We see the dermatomes, The area of skin innervated by a single nerve. We see the myotomes, muscle or group of muscle innervated by a specific motor nerve. Reflex testing, involuntary response to a stimulus. We see the deep tendon caused by stimulation of stretch reflex. We see the superficial reflex, stimulation of skin, which causes reflexive muscle contraction. We see pathological superficial reflex, indicative of upper UMN lesion. We see the Babinski sign, Chaddock sign, Oppenheim's Gordon sign, and we see for the referred pain. These are all superficial reflexes. Check. Here are the dermatomes and myotomes in our body. The dermatomes are C for collar, C5 the lateral shoulder, C6 for the thumb, C7 heaven, C8 for the pinky fingers, T4 for the T4, T7 for the xiphoid process, T10 for the belly button, L1 for the inguinal ligament, L4 for the medial malleolus, L5 at the top of the foot, S1 for the heel, at the myotome, C5, shoulder abduction, C6, the elbow flexion, C7, elbow extension, C8, wrist flexion of flexor dorsal fascialis, T1 for the finger abduction, L2 for the hip flexion by iliopsoas, L4 for the knee extension for quadriceps femoris, L5 for the dorsiflexion, tibialis anterior, S1 for the plantar flexion at gastrocnemius. Then we go for the motor testing. Here we see the testing joint stability, testing accessory motions, testing the functional performances. It used to determine athlete readiness to participate or continue participation. The other tests are the postural, anthropometric, and volumetric. The documenting injury evaluation information are the SOAP notes or SOAP notes. Record keeping can be performed systematically, which outlines subjective and objective findings as well as immediate and future plans. The SOAP notes allow for subjective and objective information, the assessment, and the plan to be implemented. Here is the SOAP note for counseling. S stands for the subjective information relevant to what the client reveals in the session. Example, the client reported changes in mood and low energy level. O stand for the objective, factual information, example, symptoms, the client appearance, orientation, behaviors, mood or affect. Example, the client was oriented in 3 times. A stands for the assessment, your clinical impression and interpretation of the objective and subjective information. Example, depressed mood and depression. P stands for the plan. What do you think as a clinician plan to do with the client, the plan of care, the next session, give a psychiatric referral. The additional diagnostic test, we go for the x-rays to identify if there is any fracture or is there any spur. We go for the arthrography, we check for the joints, we check the arthroscopy, we do the CT scan, MRI for the further evaluation, myelography, we go for the bone scan, DEXA scan, and LT ultrasonography. Moving on to the echocardiography, the electrogram, electromyogram, the nerve conduction velocity test, NCVT. We check for the synovial fluid analysis. We check the blood test. We check the urine analysis. The ergonomic risk assessment. If working in a clinic or industrial setting, an athlete trainer may be called upon to perform the assessment. Involves evaluation of factors within a job that increases risk of someone suffering a workplace related ergonomic injury. As we have seen nowadays, many people complains of the back pain whilst having a sitting job or a long time sitting. They usually get a back pain or neck pain or cervical issues. We assess aspect and movement that could be modified to reduce the risk. For injury prevention and intervention through ergonomic control measures and injury statistics. The steps and tools of risk assessment. We identify and prioritize jobs. We maximize impact of intervention. Workers must be briefed. Review injury statistics, worker concerns, physical demands, analysis. Direct supervisor must be notified, and why the modification and what new expectations will be. The management must be informed, be aware of cost associated injuries, benefits of ERA. The company support professionals, nursing staff, engineers, safety personnel, the use of videotape to allow more access for people to assessment process be utilized for training purposes as well. After risks have been identified, the athletic trainer should identify those that should be controlled in an effort to reduce injury rates, to consult workers, the supervisors and management. They may involve physical changes to job, sitting versus standing, altering work surface, the administrative changes, job rotations, lifting policies, the personal protective equipment. The proposed changes should have an error performed on them to ensure that original risks have been reduced without introduction of new risks. This is all it for the off-field assessment. Thank you.